Okay, so I wanted to go through and look at these respiratory volumes and capacities separately, just because they can get a little bit complicated, and I thought we could spend a little time looking at them. So in lecture, we touched base on the fact that you have this volume of air that you're able to breathe in and out with each breath. And so we call this our tidal volume. And for a typical, average tidal volume, it's going to be about 500 mLs. And so what we see is as we breathe in, our volume is going to increase, and as we breathe out, it's going to decrease. And we could just kind of, as we take breaths in and out, this is what our wave would look like here. So that's tidal volume. That's an important lung volume that you should definitely be familiar with. So if any of you guys have had pulmonary function testing done, like spirometry, like maybe you have asthma or that sort of thing, you may have been asked to do some of these tests in dealing with that. So one of the other important lung volumes that you need to be familiar with is inspiratory reserve volume. And so basically, a lot of times these names will tell you exactly what they are. So inspiratory means we're going to be inspiring, and reserve volume. So it's not a volume of air that we typically use like at rest, but it's a volume of air that we still have access to when we need it. So for example, if we had a patient and we were doing pulmonary function testing with them, and we wanted to measure their inspiratory reserve volume, we would have them breathe normally, normal breath in, normal breath out, and then we would say, okay, breathe in as hard and fast as you can, breathe in as much air as you can. And so what's going to happen is they're going to suck air in, all the way in as much as they can, and then that's it. They're going to start letting that air back out again. Okay? So that volume of air that they were able to suck in is inspiratory reserve. Okay, so on the flip side of that, we can also ask patients, they're hooked up to their spirometer, and we can say, okay, I want you to breathe out as much air as you can, out past your normal breath out. How much air can you breathe out in total? So we're going to pick up this tracing here, and I'm going to say, okay, breathe out hard and fast, breathe out, 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 all the way, get all the air out that you possibly can, and that's going to be our expiratory reserve volume. Okay, so I'm honestly not as interested in you knowing actual numbers for these as just what are they, how would you test them with a patient, that sort of thing. So there's our expiratory reserve volume. Okay, now it's kind of interesting to note that there's always air left in our lungs. Okay, we can't get all the air out, so there's always something that's left, and we call that our residual volume. And that kind of makes sense because it's residual, it's always there, you really can't get it out, and we don't really have access to it. It doesn't really contribute to gas exchange. This is kind of, one of the sources of residual volume is our anatomical dead space. It's just air that just happens to be in the pathway that doesn't contribute to gas exchange. So here's residual volume down here. And so that's going to be kind of this volume of air that's just hanging out. Doesn't really do much for us. Okay, so then we can take these four volumes, which are really important, and we can combine them to create capacities. Okay, so capacities are made of multiple volumes that we can add together. So here's our inspiratory capacity, and that kind of makes sense because it's basically how much air can we inspire in total. And so what we can do is we can do inspiratory capacity by taking our tidal volume here and adding it to our inspiratory reserve volume. So if we were to, add all of this together, that's going to be our inspiratory capacity. So how much air are we capable of inspiring? Okay, we inspire a little bit of air with our tidal volume, And then we can inspire a lot more air with our inspiratory reserve volume. Okay? And then we have another capacity. This is your functional residual capacity. And this is basically going to be our expiratory reserve volume plus our residual volume. Okay? So here, if we add these two together, it's going to give us our functional residual capacity. Okay? Another capacity that's important is our vital capacity. And this is basically how much air do we have access to, right? We have access to our tidal volume. Okay? That's the air we breathe in and out with every breath. We have access to this. We may not use it all the time, but we have access to it. And we have access to this, right? So we're able to take this big breath in, this big breath out, and we have access to all of that air. So we can add all of that together, and that creates our vital capacity. So vital capacity is going to be equal to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. Okay? So again, vital capacity is going to be all of the air that we have access to. We can use it all if we needed it. This is going to play a role in another measurement I'm going to talk about in just a second called forced vital capacity. Okay? So we'll talk about that in just a second. So basically they're equal. I don't want you to get confused. They're forced vital capacity and vital capacity are equal. The forced is just that you're doing it kind of like, you know, as quickly as possible. So, and then we've got our total lung capacity. And so this is going to be everything. This is our inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. Okay? So basically everything that we can put together makes up total lung capacity. And that tends to be around 6,000 mLs or 6 liters. But that includes this residual volume down here, you know, even air that we don't really have access to. Total lung capacity. Okay? So a couple things with this. We have two types of lung pathology, and I've got these spelled out in your lab outline. So one of them is obstructive, and one of them is restrictive. And so lung diseases can fall into either one of these categories. So the hallmark of obstructive pulmonary disease is the fact that you have decreased radius of your airway. So like in a condition like bronchitis, instead of having this nice big lumen of your airway, we've got, it's all clogged up with inflammation and mucus and everything, and so our airway gets much smaller. What just happened to our resistance? Resistance went up. What happened to our airflow? Airflow is going to decrease, and we have a more difficult time getting air in and out. So the thing that's interesting about obstructive pulmonary disease is that we tend to not be able to get all the air out before we need to take the next breath in. It takes so long to expire the air that it's time for our next breath. So what happens is that we don't get all the air out, okay? So these guys end up kind of like getting puffed up, like their lungs get puffed up. And what happens with obstructive pulmonary disease is that their residual volume, let me see. Huh, I don't know why I can't erase it. Okay, oh, hold on. Oh. Their residual volume is going to increase. So they can't get all the air out before the next breath needs to come in. So their residual volume, instead of being like 1,200 mLs, is going to start encroaching into their actual, like, you know, air that they use to breathe. okay, if that makes sense. So residual volume is going to increase in patients with obstructive pulmonary disease. Another example of obstructive pulmonary disease is emphysema. And what we have with this is that those alveoli, those nice healthy alveolar sacs, break down, the walls between them break down. So instead of having all these nice individual alveoli with that increased surface area, we now have kind of like a big bloated alveoli with decreased area for gas exchange. Okay, so decreased surface area, decreased gas exchange going across those alveolar membranes. So I gave you a list on your handout of pulmonary diseases that fall under that obstructive category. So they would be asthma, bronchitis, emphysema, and then conditions like cystic fibrosis, where the body makes excess mucus and clogs up those airways. On the flip side of things, we have restrictive lung diseases. Okay, so this is a different type of lung pathology. And so what happens with this is you end up having a decrease in your total lung capacity. So if we look back at this picture here, what we see is instead of it being a total lung capacity of 6,000 mLs, with a restrictive lung disease, maybe our total lung capacity we've shortened it up, and now we're down to like something like 4,000 milliliters of oxygen, or of volume of our total lung capacity. So I always tell students, like, think about this like you've taken an ACE wrap, like the thickest, strongest ACE wrap you can, and you've wrapped it around your chest. And there's no way that, you can't breathe. It's basically squeezing you. That's what a restrictive lung disease is like. So not only can they not get the air out, they have trouble getting it in. Everything is smaller. So a lot of times these are due to postural issues, damaged nerves or muscles of inspiration, that sort of thing. I gave you a list on your handout of pathology related to restrictive lung disease. This would be one of them. This is one example. Obviously, this is a very extreme case of scoliosis, but what do you think is happening to his rib cage here? So he's not going to have that nice expansion that we would get when we take a big breath in because of this biomechanical malalignment that he's got here. So obviously this is one kind of extreme case. Pneumonia also results in a restrictive lung pathology where you can't get the air in or out due to decreased lumen size. Sarcoidosis is a lung pathology that affects air movement in and out. And then conditions like ALS, or amyotrophic lateral sclerosis, where you basically have damage to the muscles, paralysis that's going to affect how much air you're able to move. Okay, so what do we end up seeing with this? There's a calculation that we can do to measure lung function and to see if there's presence of an obstructive lung disease. Okay, so so here it is. So this is called FEV1 over FVC. Okay, so what we have with this, I want to talk about this because you're going to hopefully get to work with this in your lab. This is a clinical test that we can do to assess for the presence of obstructive lung pathology. Okay, and what we do with our patient is we hook them up to a spirometer and we ask them to take a big breath in, breathe in as much air as they can, and then we tell them to blow it out as hard and fast as they can. So they're going to blow out that air as hard and fast as they can. Okay, so the first measurement we can take from this is this here. This is our forced vital capacity. right? And if you look back, sorry, I'm jumping around, but if you look back to this is what we're looking at here. Here's our forced vital capacity. And forced just means we had them do it quickly, okay? So this is measuring a combination of volumes. This is measuring inspiratory reserve, tidal volume, and expiratory reserve. So we're looking at all three of those. So we have them breathe in, breathe out as hard and fast as they can, and we measure their forced vital capacity. Now, another thing that we can do with this is we can actually take a measurement, and that FEV1 means forced expiratory volume in 1 second. So how much air of this total air were they able to blow out in 1 second? How quickly can they get that air out? And that's an indication of whether or not a patient's going to have obstructive pulmonary disease. Again, if any of you guys have had asthma testing, you probably did this. This is probably very familiar to you. So how much of that air could they blow out in that first second? Okay, and we take that number and we create a ratio and we calculate a percentage. Okay, so let's take a look at that. I worked out a couple examples here. So let's say we have a normal person, not a healthy person. So let's say that they're, so we're basically looking at FEV1 over FVC. Okay, and let's say our person had a forced vital capacity of 5,000 mLs, and they were able to blow out 4,000 of those mLs in the first second. Okay, so we're going to divide 4,000 by 5,000. It's going to give us 0.8. We always want to express FEV1 over FVC as a percentage. So we're going to take 0.8 and we're going to multiply it by 100 to make it a percent, and that's going to give us 80%. Okay, what does that mean? So that patient was able to get out 80% of their vital capacity in 1 second. Okay, what's our cutoff here? What do we want to see? So anything less than 70% is indicative of obstructive pulmonary disease. Okay, there's your cutoff. So, and you'll find that this fluctuates just a little bit depending on the source, but let's, for our purposes, let's use 70%. So if any of these numbers are above 70%, then they're considered to be normal. Okay, that would be a normal finding. So you should be able to get out at least 70% of your vital capacity in 1 second. That means you've got good airflow. All right, let's do another one. Let's say we've got another example, and we've got our FEV1 over FVC, and we have a patient comes in and they've got the same FVC. They've got 5,000 milliliters here, but they were only able to get out 3,200 milliliters in that first second. Okay, less air flowed out in that first second, right? We divide 3,200 by 5,000, and we're left with 0.64 times 100 because we want to express it as a percentage, and we end up with 64% as their FEV1 over FVC. What do you think about this compared to this? Right? That's a problem, right? It's less than it. So we're going to say, okay, in this example, this patient presents with an obstructive lung pathology. Okay? Could be emphysema, could be bronchitis, could be asthma. And a lot of times what happens with these guys is that, let's say someone is having an asthma attack. This is the way that they're going to assess whether the inhaler that they've chosen for you is effective. So they would calculate your FEV1 over FVC, initially get a number there, and then have you use your inhaler and then recheck to see if it improved. Okay, because what we would want to see is this number go up. Okay, so I think that that's pretty much it for these guys. These last two are just a couple slides. I just want to, talk to you a little bit about, primarily on this one, about how it's just so perfect that we have two different pleural cavities. So if you end up having some sort of wound on one side, creating a pneumothorax, and which would be air in the thoracic cavity, and basically, if you damage that barrier, and you end up equalizing pressure between between your intrapleural space and your atmosphere, so like in here and here becomes equal, we basically lost that suction that holds our lungs out against the inside of the thoracic cavity. And so that lung, it just collapses because lungs are spongy and they need something to suction them out, to hold them open. So you can actually have a collapsed lung on one side of your thoracic cavity and a completely normal lung going on the other side. So, which is a good thing. So if this ever happens, it buys you enough time to get to the hospital so that they can take care of it. So, importance of two pleural cavities. So, okay, that's good. Thank you.